So objective of the talk today will be, I will just basic of ultrasound, I will talk, not much details. Then we will discuss about key landmark structures, cerebral anatomy. This panelist is again coming, Said. Okay. Key landmark structures, cerebral anatomy, we will discuss a little bit, and then the standard ultrasound views, which is coronal and sagittal view. And finally, a little bit about Dopplers and measurement of ventricles and normal variants. So the aims of ultrasound in NICU is basically three: that to see the presence of structures of brain anomalies or brain injuries, to look for brain maturation, timing of brain injury, and the neurological prognosis of the infant in terms of ultrasound. There was a nice article recently published by Australian group about the ultrasound prognosis in the future neurodevelopment. So while interpreting the cranial ultrasound, it is very important to pay attention to the anatomy, maturation, and the signs of pathology, whether it is congenital or acquired. And it is always better when you detect the cerebral anomalies to visualize in at least two planes. So how we can approach and interpret the cranial ultrasound? First, to see the anatomy. Are the structures appear normal? Are they distinguishable? What is the maturation of gyri and sulci appear, which is appropriate for gestational age or no? And also to distinguish between the gray and the white matter. Echogenicity of the cortex, it is echogenic according to the normal cortical gray matter or no? And also echogenicity and homogeneity of white matter, is it appear normal or abnormal? And the same holds for the gray matter as well. And finally, to look for the ventricular system, its size, lining, echogenicity, dilated, and the measurement. And finally, the width of the subarachnoid space and whether there is any midline shift or no. So this is just a basic view of the ultrasound machine. If you can see here, there are different buttons as well. So most important is the gain to adjust on these buttons, and also the focus and the depth. I think I lost my, okay. So some technical consideration about ultrasound. We have to choose the appropriate size probe and adjust the depth and focus with these buttons, adjust the gain as well. Gain is basically to that the image while you are doing is not too bright and not too dark, not to, in order to not to miss any pathology. Then we make sure that there is a right and left labeling is correct, planes of consideration, and use of any previous ultrasounds. So it will be more clear as I go further in my presentation. So how does the ultrasound works? So in the probe which you are putting on the head of the baby, there is a crystal called piezoelectric crystals, and there is a wire. And when it is connected to the electric current, that crystal then vibrates and it generates a sound waves, which then propagate into the body and the tissue. And then after it come across any object in their pathway, those echoes are reflected back into the probe. And this way the image is formed in the machine. So this is a basic illustration. If you see, the red ones are the sound waves which are being emitted, and the blue is the object. So if they found any object in their pathway, the echoes are reflected back into the machine and the image is thus formed. There will be quite frequent use of this echogenicity in my presentation. So just to make this concept clear at this moment, that echogenicity is the ability of tissues to transmit or reflect the sound waves. And it can be divided into three different hyperechogenicity, when the surface bouncing the sound more and the tissue on the ultrasound will look more bright color as compared to the surrounding. For example, choroid plexus, hemorrhage, infarction, and calcium, it will look more bright. And if it is opposite, if it is hypoechogenicity, when the tissue reflected less, then the color is a little bit darker. And the gray matter look less echo dense than the white matter, and the sulci appear more echo dense. And if the sounds are not bounced back, then the structure will appear completely dark, for example, CSF. So this one showed you a little bit about the acoustic impedance. If you see here, if the fluid is there, the particles are quite separate apart. So the sounds goes in and some of it is reflected back. So most of it is transferred through the fluid, and it will appear anechoic, for example, blood or CSF. And as the particle get more and more concentrated, the black changes from gray to white, and if it is quite concentrated, none of it goes back and it appears like hypoechoic, like a bone. Very important about the transducer. In order to get a good image quality, we have to use an appropriate side probe with a frequency ranging between 7.5 to 8.5. And you have to compromise between the resolution and the penetration. If you want to use a high frequency probe up to like 10 megahertz, this will give you better resolution but less penetration. Please use this probe when you are viewing the superficial structures, not the deeper one. And if you want to look for the deeper structures, then use a low frequency probe up to 5 megahertz, which give you less resolution but better penetration. Usually in the term babies with thick hairs, we use the lower frequency probe. And in the probe, if you see, there is like a tubercle or a ridge on one side, and this correspond to the edge of the image, and also wherever it is, it will correspond to the right or the left side. So, and the top part of the image is usually close to the probe, and the rest is as far we go further down. Then coming to the views, basically there are three views you should know. One is the coronal plane, in which the body is divided into front and back. Sagittal plane, the body is divided into right and left, and the axial plane, in which the head is divided into upper and the lower half. Let's go now to the key sonographic landmark and structure. So these are very important in order to understand later in part of my presentation. So the standard views are basically two: the coronal view and the sagittal view. Then we have to identify the interhemispheric fissure, Selvian fissure, choroid plexus, and the germinal matrix, cavum, septum pellucidum, corpus callosum, and then the gray matter and ventricular system. So in the coronal plane, if you see, divided the brain into front and the back, and this is oriented in such a way that the right side of the baby is projected on the left of the image. So right side is on your left side, and the left of the baby is on your right side. And when you do the sagittal plane divided into right and the left half, so the front of the head is on your left side. This is the anterior, and this is the posterior. This one you will understand all the structures as I go further in my presentation. So now the important landmark is the interhemispheric fissure, which divide the brain into right and the left, and it is marked as here. It contains the falx cerebri, and it is a midline structure. Selvian fissure is a deep groove, and it divides the frontal and the occipital from the temporal lobe, and it is also called the lateral sulcus. You can see mark it as red. Choroid plexus is another important landmark to identify. It comprises of two echogenic structure which lies in the floor of the lateral ventricle. These are the two choroid plexus, and if you see, these are echogenic. They are more bright as compared to others. And they are best seen in the sagittal plane extended from here. This is a caudothalamic groove around the thalamus in the lateral body. While in the coronal plane, they can be seen in the floor, as you can see here. And these are the black one are the lateral ventricles. So in the sagittal plane, it extends from the caudothalamic groove and surrounds the thalamus. And we all know that these are important for producing the CSF. Germinal matrix are highly vascular subependymal collection of tissues which form the wall of all the ventricle, and they are very prominent during the first trimester, and normally they gradually regress and persist only on the head of the caudate nucleus in the caudothalamic groove. And it is the source of primitive neuronal cells, the neuroblast and the glioblast, and virtually absent in the full term. So if you see here, these are the germinal matrix in the sagittal plane, and here this will be in the coronal plane. Cavum septum pellucidum is another structure to identify on the ultrasound. It's a midline fluid-filled structures between the two horns of the lateral ventricle, and this is the cavum septum pellucidum. And it is a fetal neurodevelopmental marker as well, and sometimes it is absent in the fetus as well. And if it is absent, always suspect septo-optic dysplasia and callosal agenesis. Usually it fused by 6 months of age. Sometimes in 15%, it persists in the adult. And it's very important that we should not mistake it for the third ventricle. The third ventricle lies below the septum pellucidum. If it is absent, you can see somehow this ultrasound pictures like this. And this is another way to show you in the coronal plane. This is the septum pellucidum. On each side are the lateral ventricles. Corpus callosum is another midline structures which contain the horizontal fibers which connect the two ventricles. This is being shown here in the green. And this is the largest of white matter, contain about 200 million plus axons. And if you can see here, its components are the rostrum, most anterior part, and then the genu, body, and then finally at the back is the splenium. And it is very important for eye movement, cognition, and tactile localization. If it is absent, then the person cannot recognize the right and the left. And it also forms the roof of the lateral ventricle. And it ultrasound in the sagittal plane, it looks like this. And in the coronal plane, you can see here on the top corpus callosum. Then come the basal ganglia, which is very important gray matter structures at the base of the brain, and important for motor learning, eye movement, and motivation. And it composed of thalamus, caudate nucleus, and the globus pallidus and putamen. In the coronal plane, you will see it on the lateral side of the third ventricle. This is thalamus and caudate nucleus, and in between these a caudothalamic groove, very important structure. In the sagittal view, you will find this T as a thalamus and C is the caudate nucleus, and this is the lateral ventricle which encircle it. In a different diagram, it will show like this. Just to show you in this sagittal view, this pink one is the thalamus, blue one represent the caudate, and this is the green one are the choroid plexus. Caudothalamic groove is here where there is the germinal matrix, and it is very important landmark as well. And any echogenicity here in this part will represent the germinal matrix hemorrhage. Another view to see in the coronal view, the thalamus will lie here. This will be the lateral ventricle side. Caudate nucleus will be at the lateral ventricle, and caudothalamic groove will be here And this is also important structure where the foramen of Monro comes. And the sagittal structure I already explained previously. This is another diagram to show when the brain is split from the front and back. You will see the chordate nucleus on the top at the lateral ventricle side. This will be the thalamus, and further that's the chordate nucleus divided into putamen and globus pallidus. Too much detail is, I think we don't need to go in that deep, just to show you this landmarks to see that the thalamus lies just on the lateral ventricle and the third ventricle, and above is a chordate nucleus, and here will be the chordothalamic groove. Just remember these normal structures so that when later I will discuss about abnormality, you will just focus on this side. Another diagram to show about this, which I already explained. This one also, if you make the brain cut in front and half, it will show like this. This is the third ventricle, and these are the lateral ventricle. And from top to bottom, the top one, the lateral ventricle will show like this, like a hockey stick. And if you cut the brain a little bit down further in the axial plane, it will show you like this. The left ventricle occipital horns will be on the back. This will be the third, and this will be the frontal horn of the lateral ventricle. Then these are the important landmarks. Let's go further in terms of maturational changes in the neonatal brain. Because, you know, the babies are sometimes born premature, and then the major maturational changes are still ongoing. And they usually develop fetal and then later in the perinatal period. Increase in the cell size and gyration is also taking place with myelination. And general matrix is getting involuted. And also the CSF spaces are getting narrow as the baby gets mature. And these maturational changes give a specific character on the ultrasound. Gyration usually starts in the second trimester of pregnancy and continues till the term age. In extremely preterm babies, the brain surface is very smooth and has an appearance of lissencephaly. Posterior part of the brain shows faster development as compared to the anterior one. And by 34 weeks, the frontal cortex, you know, it still appear very smooth on the ultrasound, while the occipital cortex appear very mature. And by looking at these sulci and gyri, one can assess the gestational age on the ultrasound. So if you see from here, this is the brain on from the side, 24 weeks till about 30 weeks. Just see here how the sulci and gyri are very less. And as you go from left to right side, these are getting mature. And finally, at 40 weeks, you can see here quite prominent sulci and gyri. And when you cut it from the midline, you can see the structures like this. How this appear on the ultrasound? If you see, this is a coronal view in the 24-weeker, very smooth brain, not much appreciable sulci and gyri. And this is in the sagittal section, same like smooth, and this is normal. But if you find this in a term baby, it will be abnormal. And same as in 40 weeks gestation, in the coronal plane, you will see like here sulci and gyri, and in the sagittal, how you can appreciate the sulci and gyri and the sagittal view. CSF spaces, fetus, and the very preterm infant, usually the lateral ventricle are asymmetric and larger. The left ventricle, the left lateral side of the ventricle a little bit larger as compared to the right one. And the occipital horn here is also looks a little bit wider. So these are the normal variants. However, as the brain grows, the CSF spaces get smaller and less visible. If you can see this one in the sagittal plane and compare this with the premature babies, the CSF spaces are very less, especially in the occipital horn, because the brain grows in size. Germinal matrix, as I said, it starts regressing starting from 24 weeks and onward, and by 34 weeks only remnants of it is seen at the chordothalamic grooves and in the temporal horn of the lateral ventricle. And germinal matrix appear as a small area of echogenicity, mainly in the thalamochordate notch. If you can see here in my pointer is pointed to at 38 weeks. Then finally, a few words about the ventricular system. These are the fluid-filled chambers within the brain and contain the CSF. They contain the choroid plexus and germinal matrix, and their components are a paired lateral ventricles, third ventricle, as well as the fourth ventricle. So this was basically a video, and I just get this as a still image just to show the anatomy of the ventricular system. So these light blue areas are the lateral ventricles. And this one is the third ventricle, this is aqueducts, and this is the fourth ventricle, and finally in the spinal canal. And this is a lateral view to see these are the frontal horns, these are the temporal horns, and this is the occipital horn of the lateral ventricle on both sides. Third ventricle will look like this. And here, if you can appreciate, this is the foramen of Monro. Then this will be aqueduct of Sylvius, fourth ventricle, and finally in the spinal cord. So let's open the brain from outside to inside to make this more appreciable. So the brain outside, we all know, look like this. And going internally, after we see here, this is the ventricular system. And if now I will start putting the cerebellum fit nicely on the back of the fourth ventricle. Then if we go further up, I'll start putting it the basal ganglia and the thalamus, which will occupy each side of the third ventricle on this side as well. And this is the lateral ventricle on the top. Now from each side, the parietal lobes are coming to make this on the left side as well the right. Once these two are fused, the outward structure will look like this with the median interhemispheric fissure containing the falx cerebri. So I hope this has now made it easy for you to understand the ventricular system after we remove each part of the brain separately. This diagram just to show you about how the ventricle and the CSF flows. So this pink dotted line are the germinal matrix, and then the orange one is the CSF producing choroid plexus in the lateral ventricle. And then it flows through foramen of Monro, goes into the third ventricle, and from third ventricle, they go through aqueduct, and finally in the fourth ventricle, and from the fourth ventricle, it goes from foramen of Magendie and Lashka to the brain's surface, and finally they will absorb by the arachnoid villi. So after this landmarks and the basic structures, let's go how you are going to do the scan. So in the planes to do the ultrasound, there are the coronal as well as the sagittal. So in the coronal plane, there will be 6 sections you have to do in the 6th plane. And if you see here, the arrow is pointed towards the north, which is towards the baby right side. And in the sagittal plane, when the body is divided into right and left, the notch is pointing forward. It means that the front of the brain is represented here. So let's first talk about the coronal view. As I said, you have to scan in the 6th plane. Start with the midline at the level of both ears, and then 3 cuts in the front and 3 on the back. In the front, if you see here, the C1 is just cutting the frontal cortex. Second one would be also called the pentagon view, in which you will find the Salvian fissure. The third one is the cut which you will do at the level of foramen of Monro, third ventricle here. And fourth cut will be in the fourth ventricle plane. Fifth one, you will find trigone of the lateral ventricle, and finally C6 will represent the posterior occipital parietal lobe. So let's go one by one to understand the anatomy more easy. As I said, this is a C1 through the frontal lobe. It will show, and the probe is here, right side is here. The right side of the baby, if you remember, is represented on the left side. So which structure you will find when you cut in the C1? Interhemispheric fissure in the midline. Frontal lobe would be here, and this will be the skull. If you see here, it's getting wide because it's not showing any waves to pass through. And these will be the orbits. As you go further backward through the C2 image, the important structure you will find here is the sylvian fissure here. And then this will be the frontal horn of the lateral ventricle on both sides. In between, now you can see easy septum pellucidum, which is a fluid-filled structure. And below the lateral ventricle, the basal ganglia will show like this. Now, the plane of C3, which is a foramen of Monro, you will find these structure. The sylvian fissure, you can still see. This is the third ventricle. This is a cavum septum pellucidum. Now the corpus callosum is also started to come here. You can see the midline which connect the both structures. And these are the frontal horn of the lateral ventricles. C4 structures, if you see here, this is also called a Christmas tree. And if you just see the arrows pointing, this is the base of the Christmas tree. And these are the like the green part of the Christmas tree. In this structure, from top to bottom, you will see the frontal horns of the lateral ventricle. This is the basal ganglia. This is the septum pellucidum. Third ventricle not appreciated here. Frontal lobes, you can see here. And now you can see here the cerebellum. This is the tentorium cerebellum. This is the midline cerebellum vermis. And this is the cisternum magna. Sylvian fissure is still coming here in this view. In the C5, at the level of the trigone of the lateral ventricle, the trigone is basically the area where the occipital and the temporal horn meets, these structures. So in this one, you will find the choroid plexus in the lateral ventricle, and also the parietal area in which you can appreciate the peritrigonal blush, which you will more appreciate once we see the next presentation. And this is the parietal cortex. So this view you will see when there is periventricular leukomalacia, you will find those cystic structures. But the normal brain appear like this. And finally, C6 at the level of occipital lobe, you will find the interhemispheric fissure, parietal cortex, and the occipital cortex. This view is important also for PVL. Now, the midline sagittal structures, you will take two views midline here, S1, to show the corpus callosum and fourth ventricle, and the two views on the side, S2 and S3, on the left and the right side, to look for the temporal lobe and the peritrigonal white matter. So if you take the view in the midline structures, you will appreciate the septum pellucidum, and on the top of it, the calcined gyra is called the cingulate gyrus. Below this will be the septum pellucidum, and then here will be the third ventricle. Aqueducts will come here, and then this will be the fourth ventricle. Back would be the cerebellum. This will be the cisternum magna. And in front of the fourth ventricle will be the pons. And if you go now through the S2, a little bit away from the midline, you will see these structures. FL is the frontal lobe, PL is the parietal, and TL is the temporal lobe. This will be the choroid plexus, and this is all the lateral ventricle. And if you remember, this shadow will be the thalamus, and this will be the caudate nucleus, and somewhere here will be the caudothalamic groove. Here is it's pointed here. And if you go further away, you will find this, the Selwyn fissure we will still appreciate here. And you will find the frontal lobe, parietal lobe, occipital lobe, and the temporal lobe. This view is also important to look for the parietal structures and the cystic periventricular leukomalacia in the deep cortex. Let's talk about a little bit of the Doppler study. Doppler study is mainly to measure the blood flow velocity, and usually it is taken from the anterior cerebral artery, which is seen in the sagittal view above the corpus callosum. And main thing to measure here is the resistance index, which is calculated automatically by the machine, but you should know the formula, which is calculated by peak systolic velocity minus end diastolic velocity divided by the peak systolic velocity. And the normal range is between 0.65 to 0.9. And this resistance index is affected by the extracranial factor, particularly the PDA. And from the venous Doppler, you can see the superior sagittal sinus flow. It looks like here, if you see the sagittal sinus anteriorly, this is the anterior cerebral artery, and it will appear as red. So red, if you remember by mnemonic BART, BA stands for blue away. So if the artery structures appear blue on the probe, it means the blood is going away. And RT, red, is towards the probe. And wherever you measure, you put the probe here, get the pulse wave Doppler here, and press the Doppler button, and you will find some shapes like this. Put your cursor here on the top, and the baseline here, this is the peak systolic velocity, and this is the diastolic velocity. This is just represented here to make it more clear. This is the top one, visible the systolic, and the down one is the diastolic velocity, or it will be like here. If you S minus D divided by S will give you the resistance index. The condition in which the resistance index is increased, it means that the blood flow going to the artery is very less. For example, if there is hydrocephalus, and it is one of the indication that we need to insert the VP shunt or Ommaya reservoir earlier when the resistance index is high, but also to consider extracranial shunt as well, for example, PDA. And if the resistance index is low, which is less than 0.56, it means that the blood is going too much to the brain. And the condition in neonatology mainly are the hypoxic ischemic encephalopathy or low PCO2. And the resistance index is also inter-observer variable, and it gives you fair amount of clue about sensitivity and specificity about the future neurodevelopmental outcome based on the resistance index. Finally, a few words about the ventricular measurements. Using the anterior fontanelle, we can measure the ventricular index and anterior horn width of both the ventricle in the coronal plane at the level of foramen of Monro. Ventricular index is the horizontal distance between the midline of the interhemispheric fissure and the most lateral wall of the anterior horn of the lateral ventricle at the level of foramen of Monro. And you have to measure specifically for the left and the lateral ventricles. Anterior horn width is the maximum diagonal width of the anterior horn measured at the same point at the widest point, same coronal plane. Sometimes it is very difficult when there is a porencephalic cyst. The enlarged ventricle reflects tissue atrophy rather than increased pressure. So if you see here, from A to B are the different measurement taken, but if you see, concentrate on the C, they are measuring here the ventricular index from the midline, imaginary line, till the most lateral part. They did a dotted line, and you measure this, which is called the ventricular index. And in the below, if the ventricles are dilated, you can see, appreciate here. draw the imaginary line through this, and then measure the anterior horn width in this plane. This was to show you further how difficult sometimes it is when there is a huge hemorrhage. So because you cannot appreciate the lateral boundary as well when measuring the ventricular index. And if you see here, these are some porencephalic cysts which coalesce with the lateral ventricle, and how difficult it is to measure the lateral boundary. But this is just like an imaginary line. And similarly here, when the hemorrhage is there, you just see the extent and measure the anterior horn width. So once you have taken this ventricular index, there are graphs in which you will plot, at which the horizontal line represents the gestational age, and the vertical line is the ventricular width, wherever it points. So it will be at your centile for that width. Sometimes we also measure the thalamo-occipital distance, which is the distance from the thalamus to the tip of the occipital horn. And this is also measured. So the last one, I thought we will discuss this normal post-hemorrhagic ventricular dilatation here, because it's like to see the measurements and finish it here rather than the next week. It is defined into moderate and severe when the ventricular index is more than 95th centile and the anterior horn width is more than 97th centile, which is 6 millimeter. And it will be severe when it is more than 97 centile plus 4 millimeter, and the anterior horn width is more than 10 millimeter. Single measurement doesn't contain any value, so we have to measure both sides and on the serial ultrasounds to look for the progression and any intervention required based on these measurements. And once you have done these measurements, there are graphs which divide the post-hemorrhagic ventricular dilatation into 3 categories to look for the outcome of these babies into low, moderate, and high. So this is an article published by Dr. Aldeeb in 2020, in which he mentioned these normalities. So as I previously mentioned, if it is ventricular index separate for right and the left, and plot it here to see whether it touches the green, yellow, or the red line, and this will give you about rough estimation about the prognosis. Similarly, there are centile charts available for the anterior horn width and the thalamo-occipital distance. So each day when the ultrasound, each week the ultrasound is occur, you just keep on plotting these numbers here, and it will give you a fair amount of idea in which direction the baby is progressing, whether it is towards intervention or no. So these are the important measurements in the standard scanning view. Number 1 is the lateral ventricle posterior horn, which should normally between less than 13 millimeter. 2 is the third ventricle width is less than 10 millimeter. The third one, interhemispheric fissure, normal width is about less than or equal to 6 millimeter. And finally, the subarachnoid space should have a measurement less than 4 millimeter. Few slides about normal variant structures. One is you will frequently find choroid plexus cysts on the ultrasounds. These are believed to be caused by abnormal folding of epithelium, and when they are folding, they trap few fluids and debris. Most frequently, they occur on the left side as compared to the right, mostly about 10 to 15% of babies. More than 90% resolve spontaneously by 28 weeks. And if the ultrasound, the remaining structures are normal, I don't think there is any clinical significance of these choroid plexus cysts. However, there are literature available in which they found a weak association of choroid plexus cyst with this chromosomal abnormalities, trisomy 18, especially when they are more than 1 centimeter So if you see this one, it is just like small cystic structure in the coronal plane, and this is how it looks like in the lateral sagittal view. Conatal cysts are other important normal variant. So these are the cystic areas which is supralateral to the frontal horn of the lateral ventricle in this area. They also represent normal variant. Two important cystic structures are also here, and we should not confuse. One is the subependymal cyst, if you see in this cartoon, which is located below the external angle and posterior to the foramen of Monro. This is the subependymal cyst. And also, if it is on the superior edge, most lateral part, this will be the cyst, which we'll call as periventricular leukomalacia. So coming from superior to inferior, the most lateral structure, if you find, it will be periventricular leukomalacic cyst. Below it will be conatal cyst, and finally the subependymal cyst. If you see here, the conatal cyst in the sagittal view will look like this. In the normal ultrasound in normal babies, it is very common occurrence to see the asymmetry of the ventricle, especially on the left side. If you see here, this is a little bit big as compared to the right. The mechanism why it is bigger is still unknown. And it is very important that if you find asymmetry, to see it in the different plane as well, not to confuse it with the hydrocephalus. Thank you. So we still have a time. I think we will do first a few questions, or you want me to do? There are a few quiz. We try to make it interactive, but I think Zoom didn't allow us to do the.
It's okay. If you have 2-3 questions, you can do that.
Okay.
If you have a quiz, you can do that, and then we will take the questions.
Okay. So I will need some volunteer, because it's just like, don't be shy. Just tell me about these structures represented by A, B, and C. Any volunteer who want to volunteer? This already came in my presentation, just to see how, whether you were awake or no. If no, then maybe I can request Saeed to tell me.
आपने पहले ही भेज दी. Even though if anyone cannot tell the answer through
Or
voice,
they can type it.
You can write in the question answer box.
Anyways, let's. What is the time? 40. So A is like a parietal lobe, and C is simple like choroid plexus, and B represent the lateral ventricle. It's very easy.
And it was also sir mentioned in representation as well.
Presentation. So again, this questions, what is represented by A, B, C, and D? It's also very simple now that you have now see the anatomy. So A is thalamus, B is the caudate area, caudate nucleus, C is the choroid plexus, and D is the parietal area, periventricular area, to look for the PVL. And these are the sagittal view.
Yeah. What is this, Naveed? D?
Where?
Here, down.
Oh,
yeah.
And it's the RT. I don't. The D is this one.
I know, but they wrote a D for the what? Here.
I'm not sure it is a D or it is an artifact. I'm not sure.
Okay.
I just noticed. Okay, so this is a sagittal view. What is this structure? I just sent. This is the caudothalamic notch, and this is the conatal cyst. No, that is a choroid plexus cyst, and this one, this cyst is represented by conatal cyst. Okay.
Very
Thank
good.
you.
Okay, so we can start with the question on the
Sure.
question answer group. But before that, because I think the questions related all the clinical thing which you will cover inshallah in the second talk. Am I right?
Yeah, that's why I said that first we need to understand the basic and normal,
Yes.
and then my next talk, that will be the abnormal.
So the question is, what is the importance of ventricular index? You already told us, but anyway, if you can, and anyway, inshallah, next week you will tell us about that. So to make it a more, more clear on this question, that importance of this ventricular index, that how much it is increased and when to tap. And, this is the main question about that on
Yes.
the basis of ventricular index.
So I think we have a topic on post-hemorrhagic ventricular dilatation. Someone is presenting. This will come in that, because without ventricular index, you cannot decide whether to intervene or no, because you need to know whether the ventricles are increasing along with other clinical signs, like mainly the head circumference, which is increasing. So that is so these are the three structures the neurosurgeons, they take in account, and we as neonatologists as well, to see that information is needed.
Sure. I have two senior people, of course, Professor Huff and Dr. Makbul Qadir, but I will finish these questions quickly, and then you will decide about that. Okay. So the thing is that the first question, and you answer, the other one is after lesion you find, can we go for the CT scan or MRI?
It depends. Yes. If you have find the lesion, for example, very like periventricular cystic area, so there are limitations in ultrasound. In order to get the detailed anatomy, it is recommended to do the MRI. But again, if someone is in the low income country, the MRI might not help you in future when you already see the cystic structures on the ultrasound.
Sure. Okay. So I think this is the thing, how to clean the probe. This is later on, somebody can write in box. But anyway, we'll go to Professor Huq first, and then we'll go to Dr. Makbul. Go ahead. Sir, go ahead, please.
Assalamu alaikum, Naveed. Thank you very much for a very comprehensive talk. I was just wondering, you did not mention the mastoid foramen and the mastoid view to look at the cerebellum, which I think is extremely important, because quite often on the standard view, you miss the lesions in the cerebellum. So I was just wondering why you did not mention the mastoid view and the use of mastoid foramen.
Thank you, Professor Haq. Yes, there are additional, which I missed, additional view like mastoid view and the posterior sentinel as well. So I try to keep my presentation like simple, because this was just for basics. So I think that the mastoid view and the posterior is quite advanced, especially those who are doing those ultrasounds. So that's why it's not easy to interpret those views unless someone is mastered. That's why I missed. But you are right. We should have included those mastoid and the posterior fontanelle and temporal areas view as well.
Thank you. It's just because cerebellum is a very important organ of the part of the brain. Particularly now, we recognize that the major neurocognitive disorders come from the lesions of the cerebellum. So that's the reason I just pointed that out. Thank you.
Yeah, exactly. Thank you.
Makbul. Hello, Makbul.
Yes, can you hear me?
Yes, Makbul.
Okay. Thank you very much. Thank you, Naveed, for a very, elaborative and extensive and very simplified version of head ultrasound. I know, if you can keep going on and on, there are a lot of things that we can add. But for a basic learner, and we have a lot of juniors sitting here, I think this is an excellent presentation. And if we can share it with the group, I'm sure people who are learning to do head ultrasound will learn a lot from it. So thank you very much. I have two comments on your presentation, because it's just don't take it please personally. I'm just highlighting it because a lot of juniors learners are sitting here. One is about when is about this color Doppler and color pattern on any structure. It depends on the orientation of your probe, and depending on the schematic that you have shown on the right side. It's most of the time red is going towards the probe and the blue is going away from the probe. But sometimes, if a machine is used by, especially with adults, sometimes they flip these things. So red not always suggests that is going towards the probe unless the orientation is right. So that is the first comment. The second is, we use this low frequency, probe to do the head ultrasound most of the time. But in my experience, and I have seen this, if you use this linear probe, high frequency linear probe, it gives you a better resolution. And you compromise with the depth, as you have mentioned. By the time you reach, the fourth ventricle and the lower part of the cerebellum, those views are not available because the probe frequency does not reach there. But if you use the high frequency, it gives you a better picture of the brain and also the ventricle. So these are just the two comments, but overall an excellent presentation, and I appreciate if you can share it at least in the group or with me. I really appreciate. I learn a lot. Thank you.
Why only with you? Yeah. Okay. So you should make a PDF and share it on this academic
I will.
neonatology.
Yes,
So
yes.
one more question before we close today's session. Naveed, this is excellent that we go through it, but that we don't want that everybody get the probe and start doing the ultrasound and comment on that. You know that. So please comment what the minimum requirement before somebody start doing the ultrasound of the head as a neonatologist, not the radiologist.
Yeah, so that's very important. So, there are many people who here in this
Forum.
presentation, in this forum. Some may have the facility of ultrasound machine in there, and some may not have, and some may just get like a paper form of images. So my idea of this presentation was not that I'm teaching you the ultrasound. It's basically whenever you have pictures in front of you, don't directly go to the report. Try to first judge by yourself which structure is this one, what is the abnormality, and then interpret yourself and finally see the report. And if you start doing the ultrasound, always it is better that you should have some senior or at least the radiologist who will guide you about this, because taking a probe, it has doing an ultrasound, there are certain prerequisites as well. The baby should not be disturbed. You should not press the probe too high. The gel should not be cold. Of course, the hygienic measurement has to be taken, clean the probe, and make the baby cold. So first, my advice would be to, if you go through I will share in the group, identify the structures and see the pictures first, try to orient yourself, and then slowly start learning.
Sir, if I just make advantage of that you are here. I need your comment also on that. That how someone as a fellow as thing it start doing the because the people are very enthusiastic. They just put the probe and make it out something. So we don't want that. So sir, your comment is also needed.
Well, I know that there is no real standard set for it, but in our hospital we had set our own probe in consultation with the radiologist, and it took about 3-4 weeks of training with the radiologist sitting next to you to do the ultrasound, and then our radiologist had established a particular quiz program scenario with the fellows, and therefore, if they qualified from that, they were then allowed to do the ultrasound. So I don't know that if there is a formal for a neonatologist to be trained into certification to get do ultrasounds.
Exactly. Maqbool, you have the same experience. Can you comment on that?
Yes, can you hear me?
Yeah.
Yes, very rightly, Dr. Haq has suggested that there's no dedicated, curriculum or something to do that. The more you do, the more you get proficient with. If you have the luxury, we have the luxury here of a pediatric neurologist who can read our ultrasounds and they can guide you. And a lot of the time we think that, as a novice, uh, ultrasonographer, you start picking up things and you suddenly become excited that you have become an abnormality, which is usually a normal variant. So first, start doing the normal scans on normal babies and try to, orient your brain about what you see and what you interpret. Then stabilize your hand, because sometimes, the hand movements, just the subtle hand movements of even 1 millimeter here and there can totally change the picture. And the more you do and the more you discuss it with your senior persons or radiologists, the more you learn about. And don't try to look for, the pathologies. First, try to orient yourself with the normal variation and normal patterns. And the more you see the normals, then you start picking up the abnormals. And again, my personal preference is to use the high frequency, which gives you a better resolution and more depth in the structures. Thank you.
Thank you.
Junaid, just a comment. What we found was as Naveed has pointed out, the most difficulty was with the gain. The less experienced you are, the higher the gain you put, and therefore you see brighter pictures and you get excited by seeing pathology. But in fact, adjusting the gain is the most, we found that was the most important point to teach our fellows. I don't know whether Maqbool or Naveed agree with that.
Yes, no, I totally agree. Sometimes we just keep increasing the gain and, we start picking up the pathology and also the depth sometimes, if you don't have the correct depth, the picture is too small and too big, then you miss the peripheries or you don't appreciate the normal structure. So the picture has to be central. You should see from top to bottom. That should be your appropriate depth. And sometimes with the high frequency, again, I'm coming back on high frequency, you have to increase your virtual, there is a virtual button on the machine that you have to expand the width also to get the maximum structures, because otherwise the peripheries would be cut on high frequency.
Sure. Okay, so with that, thank you very much, Naveed. Is a very good. I learned a lot because I'm not that good in emergency. Sometimes I put the probe, but definitely Maqbool here with me before is much better than me. But I learned a lot the structures and these things. But again, to young fellows and to very enthusiastic young people, please don't start putting the probe and then just interpreting. Acclimatize yourself with the machine, with the anatomy as just discussed by Naveed, and then go through some references and then do the practice and check your interpretation with either with the radiologist or your seniors and the thing. Thank you very much, sir. Thank you very much, Talal. And all.
Sir, I'm sharing one thing regarding ultrasound. So I'm doing head focus since last 1 year of my fellowship.
Okay.
So as you all mentioned, okay, I learn, even still I'm learning, but the pattern is same. Initially, I was learned the normal things, and slowly, gradually, I picked especially the intraventricular hemorrhages, and always, usually, what I am doing here, okay, when I capture the images, and I always first initially put my findings and then discuss with the team of the radiology. So this is how I improving myself, and I'm still trying to improve because it's not an easy job to pick the all structures. So once
I
again,
think this is the right way. I think this is the right way. You are doing in a very right way.
yes, sir. So thank you very much, sir. Thank you very much, Dr. Naveed Durrahman Durrani. It was very comprehensive presentation, no doubt. I myself learned a lot today, and as well all our participants. So thank you so much, Professor Khalid Haq and Dr. Junaid and Dr. Makbul Qadir, Professor Talal Wakar, and all other respected colleagues and participants. So next week is Saturday. I think वो आपकी presentation होगी उस पे IVH पे, if you remember, because Dr. Naveed presentation will be on 29th of July. Second presentation.
You are talking to me or Dr. Haq or Dr.
Sir, आपसे sir.
So, Dr. Junaid,
कुछ कर लेंगे. ठीक है. You mean that how to prevent the IVH and all those stuff? Huh?
Yes. Because
next week you may need to change. The next week Saturday को वो है symposium है और Saturday Sunday.
अरे हाँ यार ये तो तलाश है.
हाँ, I'm not sure कि Saturday उस दिन शाम को लोग फारिग होंगे नहीं, but I'm not sure. Maybe हो कर सकते हैं या नहीं कर सकते, आप देख लीजिएगा.
I think we postpone. Yeah, we will not do on that Saturday, and then we postpone 1 week further. Okay.
Then sir, on 29th will be of presentation Dr. Naveed again. So we will continue same next presentation Dr. Naveed on 29th.
29th.
Yeah. So it get the continuity, and then I will do whenever the chance is. Okay.
Sure, sir. So the next week, sir, inshallah, due to symposium, we will postpone, and inshallah, again we will meet again on 29th of July.
Chalo. Thank you.
Thank you. Thank you.
Chalo.
Thank you. Allah Hafiz.
Thank you. Allah Hafiz.